Hello, I'm Fabio Fernandes, and I would like to say thank you so much for this kind invitation to talk about the updated diagnosis of cardiac amyloidosis. Cardiac amyloidosis is still an unrecognized disease. Many patients has a misdiagnosis. In our group, we perform a study. We've seen that more than 7% of our patients looking for more than three physicians. And the type of experts consulted were general physician, nephrologist, and cardiologist. There are a lot of complementary methods that allow us to thinking about in amyloidosis, especially in diagnosis and prognosis. The ECG with low QRS voltage, QRS durations, inactive areas, or echocardiogram with a lot apical sparing, right ventricular functions, biomarkers such as NT-proBNP and troponin, even MRI with late gadolinium enhancement, T1 mapping, even ECV, and other functional capacity tests like cardiopulmonary test and 6-minute walk test allowed us to thinking about amyloidosis. There is incidence and risk factors for pacemaker implantations in patients, even with light chain and transthyretin cardiac amyloidosis. Using the ECG and the history, we can construct a score. Patients with AF history, a PR over than 200 milliseconds and QRS over than 120 milliseconds, if it has three of these risk factors, we increase 6.2 fold the risk for pacemaker implantations. So it's very important using CG and the story for a diagnosis for pacemaker implantations. Other tests that is very important and easy to perform is the 6-minute walk test distance. In this study that allowed to evaluate the prognosis of this test, in UK from the group, the Professor Julian Gilmore, they evaluated more than 2,000 patients, and they observed that a shortened in 6-minute walk test distance was associated with a more severe cardiac phenotype, and a distance low that 350 meters was associated 2.2-fold high risk of mortality in the overall populations, even in patients with wild type, patients with hereditary form, and when compare NIC stage, also there is a good correlations. Patient who has more than 350 meters has better prognosis where compare patients who has low than this distance. And also this study evaluated the change in distance in a period of in 1 year. And they observed that patients that allowed to walk more than 35 meters has a better prognosis when compared to patients who are not allowed to increase more than 35 meters. So there is a good correlations with other parameters like NT-proBNP and mortality in this study. And when compared for quartiles of this study, patients who has a more functional capacity, like more than 427 meters, has better survived when compared patients who has low functional capacity. And as I said before, the capacity to walk more than 350 meters has a better survival when compared patients who are not allowed to do this distance. It's easy, it's not cost, so it's very important to perform in your patients. Other important, interesting too, it's cardiac amyloidosis is not a uniform compromise. We have seen that patients, the amyloid burden compromise more in basal and mid-ventricular portion when compared the apical. Also, we have seen more the amyloid burden in trabecular and subendocardial areas. This is a histopathological study. And there is also a good correlation with left ventricular thickness when we compare amyloid burden. So amyloid burden correlate positive with left ventricular thickness, and an inverse correlation, the amyloid burden with left ventricular ejection fraction. However, we have seen the apical sparing, the histopathologic apical sparing cardiac amyloidosis. There are few studies that correlated apical sparing in cardiac amyloidosis with histopathological studies. In this study that performed in 27 heart specimens and compared with 11 echocardiogram, they observed 20 25%, only 25% of the patients has amyloid gradient, or seen that more amyloid burden in base when compared to base, to apse. However, 75% of these studies, there is no amyloid grading. Other explanations for that were myocard fiber orientations, apoptosis in basal regions, and a very important method to try to explain this is small vessel involvement, the compromise of the vessel by amyloid burden. And there is many example of that in patients with absolutely normal, with at least there is no amyloid burden, few compromise in amyloid tissues, and patients with severe longitudinal strain, high amyloid burden, we've seen in red Congo tissues with bright polarized seen in green appearance, high amyloid load, and relapse amyloid gradient, apical sparing amyloid gradient, more in base when comparing apical areas. However, we've seen apical sparing, but no amyloid gradient, and we've seen the vessel, we've seen a compromise in the vessel. We also detect the limitation of apical sparing pattern in cardiac amyloidosis in patients we did with Dr. Robert Lang and Dr. Jeremy Slivnik, multi-center study, more than 500 patients with amyloidosis, and compared to 2,300 control. The aim of the study was the evaluation of diagnostic accuracy of apical sparing ratio in patients with cardiac amyloidosis when compared control. And we observed 72% sensitivity, 66% of specificity, and apical sparing was present in only 32% of the patients with cardiac amyloidosis. However, we also observed this event 6% of apical sparing in health subjects. When present, allow us to thinking about in amyloidosis. However, is not so specific when we think before. Other cardiac methods that echo allowed us to do a correct diagnosis, it's left ventricular glomerular strain, even in left atrial strain, and they are correlated with also prognosis. Patients has low left ventricular and left atrial strain has worse prognosis, worse survival when compared patients with better longitudinal strain and atrial strain. Even in left ventricle, even in right ventricle. This has allowed us to try a prognosis in our patients using echo. Echocardiogram also allowed us to follow a specific treatment in patients who was treated with a specific treatment in amyloidosis like tafamidis. We are able to detect and follow patients who in the ASTRACT study that receive 8 milligrams of tafamidis when compared to placebo. We observe a normal preservation of left global longitudinal strain in patients treated with tafamidis when compared to control. Even diastolic functions were better in patients treated when compared placebo. So we were able to use this method of the systolic function and diastolic dysfunction to follow patients treated with specific treatment of amyloidosis. We also use the echo in our group in a study recently published in patients with cardiac amyloidosis that suffer from thromboembolic events. But these patients has sinusal rhythms. There is no atrial fibrillation. We observe that patients that interventricular septum diameter at 3 millimeters increase 2.09 fold the risk of thromboembolic events even in patients with sinusal rhythm. So maybe correlated with amyloid burden in septum, more diastolic dysfunctions, we increase the risk of thromboembolic events. We also try to use a new method we call shear wave elastography. Shear wave elastography is a method that are using since the Hippocratic times, when only you using the palpation of the tissue, you see the thickness of the tissues. In shear wave elastographies, you use ultra-fast ultrasound imaging. In common ultrasound imaging, you usually use 25 to 50 frames per second. But when you use in the shear wave elastography, you use more than 2,500 to 5,000 frames per second. And we are allowed to use in the anterolateral left ventricle, in the right ventricle, in the inferior area, in patients with cardiac amyloidosis and patients without amyloidosis. And we observe that patients with cardiac amyloidosis has more myocardial stiffness assessed by shear wave elastography when compared patients without cardiac amyloidosis. And when we construct the ROC curve, we see that 4.6 kilopascal velocity are able to detect cardiac involvement. And other point very interesting, we also see in these patients without cardiac involvement assessed by left ventricular thickness in the echo and MRI, also has more myocardial stiffness. These patients were detected like neurologic phenotype and maybe using a more sensitive technique are allowed us to complete the diagnosis, early diagnosis of cardiac involvement. And we are follow our patients with specific treatment and follow the response. The responders has less myocardial stiffness when compared as no responders. And when also there is a good correlations with right ventricular brain atrophic peptides, troponin, and there is inverse correlation, especially with BMI index and functional capacity test like 6-minute walk test. So this test may able to early diagnosis in patients with cardiac amyloidosis. Other point we would like to discuss and a new tool to try to thinking about a new tool for amyloidosis, that patients with cardiac amyloidosis might suffer from pain, chest pain. And when performing coronary artery disease in these patients, 62% of these patients has no obstructive coronary artery disease. And might be because there is vessel involvement or these patients might suffer from microvascular dysfunctions, microvascular flow reserve disturbs. We are able to detect using coronary flow reserve by PET ammonia in patients with hereditary transthyretin amyloidosis with and without cardiac involvement. And patients with cardiac amyloidosis, we are able to detect low flow reserves when compare patients with normal reserves without cardiac involvement. So when we see patients with cardiac involvement, also global coronary flow reserve or specific territory like descending anterior circumflexes or right coronary artery disease has low flow reserve when compared patients without cardiac involvement. So maybe these patients might suffer from microvascular dysfunctions. So when we see these patients, we also see a gray scale that these patients might suffer from coronary flow reserve low. And there is a good correlations with scintigraphy, 6-minute walk test, and inverse correlations with pulmonary artery pressure and diastolic function. Other very important method to try to do a correct diagnosis is MRI. We are able to use T1 map. In T1 map, we are not there is no necessity to inject a contrast. Patients who has T1 mapping higher over there in this study, more over there 1,164 milliseconds, has the diagnosis of cardiac amyloidosis. Patients who has low T1 map exclude cardiac amyloidosis, may allow the diagnosis of Fabry disease or even hemochromatosis, and patients who has intermediary are a necessity to inject contrast with gadolinium. And the contrast of gadolinium, we are allowed to detect the subendocardial late enhancement, and patients with more severe forms has a transmural gradient. And we did a study because in Brazil there is more magnetic resonance than scintigraphy in many centers. And we do together with many centers in the United States, I studied using MRI, patients who has MRI typical for late gadolinium enhancement, and it excluded AL amyloidosis for accessing kappa lambda free light chain, even immunofixations in serum and urine negative, and using a positive MRI resonance, we observe a 98% of specificity when we has a typical late gadolinium enhancement, and we excluded negative light chains amyloidosis for trying a correct diagnosis and patients without need to use scintigraphy. So patients who has light chain absent and MRI pattern positive and typical, we may conclude 98% sensitivity, specificity to diagnose of TTR cardiac amyloidosis. Other thing is very important, it's biopsy, histological typing. There is a lot of scenarios to perform a histological typing. And patients with suspect of AL amyloidosis, in patients who has a grade 1 scintigraphy, and patient who has grade 2, 3 scintigraphy, plus monoclonal AL abnormalities, or thinking about infrequent types of amyloidosis. And now we are able to perform mass spectroscopy to has the gold standard for assess histopathologic tissue in patients with amyloidosis. They allow the correct diagnosis of the protein that is included in the tissues. Other thing, it's important to try to improve the diagnosis in patients with aortic disease and mitral disease. Amyloidosis might coexist in patients with different types of aortic and patients with mitral disease. Why this is happening? This is happening because there is common mechanism, elderly age, dysregulatory calcium, homeostasis, and the shear stress may clever plasminogen in plasmin that might clever more amyloidogenic transthyretin that might deposit in aortic valves and cardiac tissues. Many studies using even patients submitted to valve replacement or TAVI, showing or histopathology studies showing from 4 even to 33% the coexistence of patients might have aortic disease and even a cardiac amyloidosis. And there is a RAISE score. The RAISE score may allow us to thinking about the coexistence in aortic disease and cardiac amyloidosis. R is from remodeling. There is a severe hypertrophy and diastolic dysfunction. A, the age, more risk. E, the injury, like increase in troponin. S, the systemic, patient who might suffer from carpal tunnel syndrome. electrical, like right blood disturbs or low voltage. And we use this score, we are specificity 100% is sensitivity. So every patient we has aortic disease, we might use the RAISE score and try to think the consistencies of this both disease. Even now, we are thinking, seeing patients even with mitral insufficiency might have also cardiac amyloidosis. In these studies, patients who were succeed to mitral clip repair, they observe 11% of patients with amyloidosis. And I would like to talk new tools that are able to try to correct the diagnosis using Evusamitab is a radio tracer that allows in different species of amyloidosis may allow it to try to correct diagnosis in AL, in TTR, even other types or even hereditary forms may allow uptake of these tracers in amyloidosis. And I would like to say that the AL, they are able to detect early the correct diagnosis with these studies from Mayo Clinic model allows 2 years to anticipate the diagnosis with normal ECG. And we also perform in hours the assessment of potential transthyretin amyloid cardiomyopathy cases using a Brazilian public health system, more than 1,005,100 patients, and we observe using AL that 10% underdiagnosed case with hereditary form and 21 patients underdiagnosed case using AL. So I would like to thank again so much again for this, and I would like to thinking to finish saying citing Rob McNamara that usually use it to say, see and believe may be different. We see what we believe. As more we believe that could be amyloidosis, we are going to see more with a new eye. Thank you so much.